So good evening, guys. We are still waiting for some more people. We are starting in the next 2 minutes. Thank you. So good evening, ladies and gentlemen, and welcome to this evening's webinar on empowering women's health, redefining combined oral contraception with Estradiol Valerate and enhanced patient outcomes. So before I invite the speaker, just a few key facts about contraception and also to give you an overview of what we're going to cover. So our speaker will take us through the topic, the newest kid on the block. We will have a panel discussion for about 10 minutes. We will have a Q&A. So I'm encouraging all of us, anybody with a question or a comment or a clarification, to post those ones in the chat box. We'll be able to respond to them after the presentation. And then after that, we'll have a talk by the sponsors of the CME, that's Bayer Healthcare. So today's CME is proudly sponsored by Bayer and COGS in conjunction with the University of Nairobi and Kenyatta National Hospital. A few facts about contraception. According to the World Health Organization report released this month, that's July 2025, 1.9 billion women are in the reproductive age, that's between 15 and 49. Out of this, 1.1 billion have a need for contraception. Of the 1.1 billion women in the reproductive age who need a contraception, 874 million are using a modern contraception, which means 164 million women have an unmet need for contraception. The unfortunate thing is that most of these 164 women are in the low and middle income countries, and especially sub-Saharan Africa, where Kenya falls. We know that contraception has immense benefits, both contraceptive and non-contraceptive benefits, which the speaker will talk about. But despite these immense benefits, we know that we have significant barriers to access, issues of availability of the contraceptives, issues of side effects. We hope that the newest kid on the block will address some of these side effects that impair access, issues of politics, our culture, issues of religion, etc., etc. We have several types of contraceptives. Some are temporary, some are permanent. And this evening, we are discussing the newest kid on the block. That's a combination of Estradiol Valerate and Dynogest. To take us through the first part of the presentation, our speaker is a consultant obstetrician gynecologist, a laparoscopic surgeon with over 23 years of experience in clinical practice, both in private and is currently a senior medical specialist and the head of department of obstetrics and gynecology at Kenyatta National Hospital, a distinguished member of the World Association of Laparoscopic Surgeons, a member of the American Association of Gynecologic Laparoscopists, chairperson of the Kenya Society of Endoscopic Specialties. She is also the vice chairperson of Minimal Access Surgery Committee at KNH, a member of Laparoscopy Mashinani, and prior to the current engagement, she's held several other senior positions, both in Kenyatta National Hospital, locally and globally. She is also an honorary lecturer at the University of Nairobi, Obs-Gyn Department, and has several other responsibilities. For example, she's a former member of the Minimal Access Surgery Committee at FIGO, head of gynecological endoscopy department of OBGYN, Kenyatta National Hospital, and a former chairperson of Medicines and Therapeutics Committee, both Kenyatta National Hospital and University of Nairobi. She's well read and well published, and a recipient of the Presidential Order of Service Award. It will take me a whole day to give you the profile of our speaker. So, ladies and gentlemen, kindly help me to welcome Dr. Philomena Owende to the stage. Welcome, Dr. Owende.
Thank you very much, George, for the kind introduction. Good evening, colleagues, ladies and gentlemen. So today we stand at the intersection of innovation and empowerment in women's health. We know that combined oral contraception has long been a cornerstone of reproductive autonomy, but it's now time to go further than that. The Estradiol Valerate Dianogest combination marks a paradigm shift, aligning efficacy with better cycle control, improved tolerability, and enhanced overall well-being. So this is more than just contraception. It's a redefinition of care centered on the woman. I have no conflict, please, next slide. I have no conflict of interest. Thank you. I have no conflict of interest. In 1993, The Economist magazine named the birth control pill as one of the 7 wonders of the modern world. And this recognition highlighted the pill's profound impact on society, particularly empowering women by giving them greater control over their reproduction and family planning. They say that wonderful things come in small packets and in small pills. We know that the pill has undergone so many changes since its inception in 1960. And to make it more, and this was to make it more safe, more effective, and to increase its user acceptability. In terms of composition, we've seen a lot of changes in the composition of estrogen and progesterone component of the pill. We have also seen a lot of changes in duration of use. What we are focusing on today is this 26-2 regimen, but we have had 24-4 regimens, 21-7 regimen, and 84-7 regimen. In terms of dosing, at inception, we saw higher contents of estrogens, more than 50 micrograms, and that has gradually come down up to about 10 micrograms. And now we are looking at newer applications, basically extended use. Where else do we use these contraceptive pills? Next slide. In terms of the drug composition of combined oral contraceptives, they're divided into generations depending on the progesterone component. The first generation includes the norethindrone composition together with ethinyl estradiol. The second generation include norgestrel and levonorgestrel. Third generation, desogestrel, gestodin, norgestimate, cyproterone acetate. And today, we are going to discuss the 4th generation, Dianogest, but also in the 4th generation is drospirenone. How about estrogen? The beta estradiol is a naturally occurring estrogen. We know that already. Historically, there has been a long-standing interest in developing a combined oral contraceptive that contains a natural estrogen. But we faced certain problems with the natural estrogen because of poor oral absorption and higher rates of breakthrough bleeding, and this has prevented the change. However, with advancement in technology and micronization and esterification, enhanced oral bioavailability, we are able to produce estradiol valerate. Estradiol valerate is an ester of estradiol and thought to have a lower risk of VTE than ethinyl estradiol. Next slide. So we will discuss estradiol valerate, which during this presentation I will refer to as E2V. In combination with Dianogest, again, I will refer to Dianogest as DNG. The combination has shown significant reduction in heavy menstrual bleeding with the advantage of the estrogen being identical to body's own, and it's therefore indicated for contraception and heavy menstrual bleeding. The Fraser et al. Study was a double-blind trial that investigated the efficacy and safety of estradiol valerate in combination with Dianogest for the treatment of heavy menstrual bleeding without recognizable organic pathology. And they demonstrated an 88% reduction in heavy menstrual bleeding compared with 24% for placebo. Next slide. Back to basics. This is a very familiar structure to those of us who have studied biochemistry. After oral and parenteral administration, oral estradiol valerate is completely converted into the natural substances 17-beta, estradiol, and valeric acid. The 17-beta estradiol produced on cleavage of the ester behaves like the endogenous steroid hormone. So the estradiol valerate and 17-beta estradiol are virtually dose equivalent. In terms of kinetics, next slide. In terms of kinetics, estradiol valerate is the esterified form of 17-beta estradiol. And after oral administration, E2V is completely absorbed by the gastrointestinal mucosa and rapidly hydrolyzed to E2 and valeric acid. Within the gut, E2 further isomerized to estrone, which then converts freely back to E2 and estrone sulfate. Approximately 3% of the dose is immediately bioavailable as E2 immediately after ingestion of estradiol valerate. Next slide. In terms of classification of synthetic progestins, as mentioned earlier, this is broadly grouped into 4. We have first, second, third, and fourth generation, as earlier mentioned, but can also be classified based on their chemical structure. We have the C21 progesterone derivatives to my left, and these are the pregnans. Examples of these include megestrol acetate, cyproterone acetate, and medroxyprogesterone acetate. Effective, however, they have androgenic activity. So over time, probably not favored. Another class is the C19 progesterone, which is further classified into estranes and gonens. The estrane basically means that when broken down, it's broken down into progesterone and estrone. The gonens are neutral. Dianogest falls under the C19 nortestosterone progestogen. Of the fourth generation, but we're not going to discuss that today, except in comparison to Dianogest, there is spironolactone derivative, which is drosperinone. So successive generations exhibiting varying degrees of androgenic, anti-androgenic, and progestogenic activity has been shown as newer progestins come into the market. Dianogest, which is a C19 nortestosterone derivative, next slide, exhibits anti-androgenic activity. The compound is approximately 90% bioavailable after oral administration and is widely distributed. The majority of the drug circulates bound to albumin. However, we have a 10% free hormone circulating after ingestion. And this relatively high percentage of freely circulating hormone may lead to a more potent effect on target tissues, particularly the endometrium, than other progestins. There is no hepatic fast-pass effect with Dianogest, and Dianogest is metabolized via hydroxylation and conjugation to both weak progestins and inactive compounds, primarily by the enzyme system CYP3A4. And as you can see on this slide, it has no androgenic activity, but it has good anti-androgenic activity and no mineralocorticoid activity. And this is where it differs with drosperinone that has mineralocorticoid activity. Next slide. So the majority, as I've mentioned, the majority of the drug circulates bound in albumin and 10% circulates freely. And this relatively high percentage of freely circulating hormone may lead to a more potent effect on target tissue, particularly the endometrium, than other progesterone. And again, I will repeat, there is no very minimal hepatic fast-pass effect. Next slide. Dianogest, because of this, Dianogest has a cyanomethyl instead of an ethinyl group at the C17 position, which may make the compound elicit fewer hepatic effects. So that's the explanation why it elicits fewer hepatic or no hepatic effects than the other C19 nortestosterone derivatives. Its similarity to norethistrone is reflected in its high endometrial efficacy, which could explain the high stability of the menstrual cycle women achieve when they use DNG in combination with estradiol valerate. Next slide. In the target tissues, as you can see in this slide, 2 milligrams of estradiol valerate has a similar effect to 4 to 20 micrograms of ethinyl estradiol, with EE, that is the ethinyl estradiol, being significantly more potent, roughly 200 to 20,000 times more potent than estradiol. Estradiol valerate generally has less pronounced effect on metabolic and hepatic parameters compared to ethinyl estradiol. It has very limited lipid effect on lipid metabolism, glucocorticoids, and also glucose metabolism. Also no effect on the thyroid gland. Next slide. So what do women want in an ideal contraceptive method? Women have said that they want a contraceptive method that is easy to use, that is safe, that is effective with minimal side effects, preferably a natural method with immediate reversibility. When they want to get pregnant, they want the pregnancy now. So having discussed the individual properties of estradiol valerate and Dianogest, it's important to highlight their combined clinical value. And so the next 30 minutes is going to be on their combined value. So together they form a novel 4-phasic oral contraceptive designed not only for effective pregnancy prevention, but also for the treatment of heavy menstrual bleeding. This combination leverages a dynamic dosing regimen to optimize endometrial stability and improve bleeding patterns. Clinical trials have demonstrated its strong contraceptive efficacy, good cycle control, and a favorable safety profile, making it a versatile option for both contraception and therapeutic use in heavy menstrual bleeding. Next slide. The 4-phasic or the quadriphasic dynamic dosing regimen of estradiol valerate and Dianogest provides early estrogen dominance in order to allow endometrial proliferation and progesterone sensitivity. Combined E2V and DNG pills are then given in an estrogen step down and progestin step up approach, such that in the mid to late cycle, DNG provides endometrial stability to prevent unscheduled breakthrough bleeding. As you can see on that slide, it's very simple to follow. It comes in the form of a wallet. I think we're going to see this. The first 2 days, we have 2 pills of 3 milligrams estradiol valerate, followed by 5 days of 2 milligrams of estradiol valerate in combination with 2 milligrams Dianogest. Thereafter, from day 9 to day 27, we have 2 milligrams estradiol valerate in combination with 3 milligrams Dianogest. And then day 20, after that, there are 2 pills, 1 milligram each of estradiol valerate. Then we have 2 placebo pills. So this is what we are referring to as estrogen step down, progestin step up approach. Next slide. This might look daunting to you, but it's very simple. It comes with very clear instructions, but I'm going to summarize that when counseling patients on the E2V, DNG, 4-phasic pills, it's crucial to emphasize the specific guidance for missed pills, which differs slightly from the traditional combined oral contraceptives. And because of its dynamic dosing regimen, missing pills, especially in the early phase, can significantly affect contraceptive efficacy. So clear patient education on what to do if the pill is missed is essential to maintain both contraceptive protection and cycle control. Next slide. So the combination, the 4-phasic pill, E2V, DNG combination, missed pill rules are very straightforward. It looks daunting, but it's easy. It's uncomplicated. If one active pill is missed less than 24 hours late, it should be taken as soon as remembered, and no backup is needed. If 2 or more pills are missed 24 hours or more, the last missed pill should be taken immediately and the rest discarded, with backup contraception advised for the next 9 days. The goal is to minimize hormone-free intervals to maintain contraceptive effectiveness and timely pill intake, especially in the early phase of the cycle. Next slide. Graziotin in 2016 her review underscores the clinical advantage of shortening the hormone-free interval in combined oral contraceptives. At your own time, you could read this study. It was a 2016 study, not very long ago. So the evidence here shows that reducing or eliminating the traditional 7-day break helps maintain more stable hormone levels, minimizing follicular development and reducing the risk of escape ovulation. This translates into improved contraceptive efficacy, better cycle control, and reduced hormone withdrawal symptoms, supporting the shift towards regimens like E2V-DNG that use a shortened and modified hormone-free interval. Next slide. She further frames menstruation as an inflammatory event. This we already know. And menstruation is characterized by elevated prostaglandins and cytokines, which can exacerbate symptoms like pain, mood changes, and fatigue. Therefore, shortening and modifying the hormone-free interval not only enhances contraceptive efficacy, but also reduces the frequency and intensity of these inflammatory symptoms, offering meaningful quality of life improvement in women. Next slide. Biza in gynecological endocrinology discusses how hormone withdrawal associated symptoms, abbreviated as HWAS, in women using combined oral contraceptives are often overlooked and underexplored. We tell women that it is normal to have period pains. We also tell them that you can brave it. We often tell them that we have lived with it, so you can also live with it. But this study highlights that these symptoms, which include headaches, pelvic pain, bloating, amongst many other symptoms that women report, are frequently experienced during the hormone-free interval of the contraceptive cycle. Next slide. Therefore, E2V-DNG is known for its 2-day hormone-free interval. This shortened interval, combined with the dynamic dosing regimen, aims to provide effective contraception while maintaining stable estradiol levels and a satisfactory bleeding profile, as we're about to see. Next slide. Frusetti, again, you can read at your own time, emphasizes the shortening the hormonal-free interval in combined oral contraceptives may help interrupt the inflammatory cascade triggered during withdrawal bleeding. And this cascade, involving elevated prostaglandins and inflammatory mediators, is responsible for many of the painful symptoms women experience, such as dysmenorrhea, headache, pelvic discomfort. And by reducing the duration or eliminating the hormone-free interval, regimens like E2V-DNG can provide significant symptom relief and enhance overall tolerability and compliance. Next slide. Macias Garcia et al. Further demonstrated that E2V-DNV 4-phasic oral contraceptive significantly reduces hormone withdrawal associated symptoms such as headache, pelvic pain, breast tenderness, amongst many others, compared to traditional ethinyl estradiol-based regimens. And the dynamic dosing of this combination and the shortened hormone-free interval of E2V-DNG contribute to a more stable hormone levels, which helps minimize the drop that typically triggers hormone withdrawal associated symptoms. This makes the combination a well-tolerated option that addresses both contraceptive needs and quality of life concerns that are associated with hormonal fluctuations. Next slide. Jensen, JT's evaluation of the new estradiol-based contraceptive, specifically the E2V-DNG combination, highlights its favorable profile in terms of contraceptive efficacy, cycle control, and tolerability. And unlike a traditional ethinyl estradiol containing pills, this combination uses estradiol valerate that is a bioidentical estrogen, which may reduce estrogen-related side effects and offer a more physiological hormone environment. He further found that E2V-DNG was an innovative option that meets both contraceptive and therapeutic goals, with the added benefit of improved patient satisfaction due to reduced hormone withdrawal symptoms and better bleeding profiles. E2-DNG provides reliable contraceptive efficacy with a PAL index typically around 0.79 in women aged 18 to 50, according to a pooled analysis of clinical trials. We know that the PAL index is a statistic measure for contraceptive efficacy. If it is lower than 1, then that is what is preferred. Basically means that in 1 year, out of 100 women using one method, how many will get pregnant? And that is how it is calculated. And the 4-phasic regimen, which involves varying doses of estrogen and progestin throughout the cycle, is designed to mimic natural hormone fluctuations and potentially improve bleeding patterns. And studies have shown that the combination can lead to a reduction in heavy menstrual bleeding, with some women experiencing a significant decrease in blood loss. The combination compared to other COCs, and some studies suggest it may offer a better bleeding profile. Next slide. Burnett and Dinger's research highlight that in real-life use, the combination, that's the 4-phasic pill, outperforms other COCs, including those containing levonorgestrel in terms of contraceptive efficacy and heavy menstrual bleeding. Their findings reflect lower typical use, failure rates, suggesting better adherence and tolerability, likely due to the improved bleeding profile and reduced hormone withdrawal symptoms associated with the combination. Next slide. Aren et al. Found that women using the combination experience considerably lighter scheduled bleeding compared to those on traditional EE levonorgestrel pills. Next slide. He further demonstrated that the combination provides a good cycle control comparable to low-dose EE levonorgestrel formulations. And despite its use of natural estradiol valerate instead of synthetic EE, E2V-DNG maintains a consistent cycle regularity and scheduled bleeding predictability. This basically reaffirms its reliability as a contraceptive option while offering additional benefits such as reduced withdrawal symptoms and lighter bleeding. Next slide. In terms of cycle control, there's a lot of work that has gone into this, and this study quoted on this slide compared the bleeding pattern, cycle control, and safety of an oral contraceptive comprising E2V-DNG administered using a dynamic dosing regimen with a monophasic oral contraceptive containing EE levonorgestrel 100 micrograms. And the conclusions from this study was that a novel oral contraceptive composed of E2V-DNG is associated with an acceptable bleeding profile that is comparable to that of EE-containing oral contraceptives. Next slide. Archer et al. Further reported that E2V-DNG regimen leads to significant improvement in menstrual cycle characteristics, including more predictable bleeding patterns, reduced incidence of unscheduled bleeding, and overall better cycle control. Next slide, please. UQ et al. Highlighted that E2VDNG significantly improves bleeding patterns compared to traditional COC. Next slide. Biza et al. And Fraser, Biza's work was in 2013, and Fraser et al. In 2011, both underscored the benefits of E2VDNG regimen in improving menstrual bleeding outcomes. I think it's a high time we stop saying that it is normal for women to bleed, to have heavy menstrual bleeding. And these two people, their studies highlights enhanced user satisfaction due to reduced hormone withdrawal symptoms and better bleeding control, while Fraser's clinical trials confirm that E2VDNG is effective in treating heavy menstrual bleeding, even in women without organic pathology. Next slide. This classification system is familiar to us. According to Munro et al., on behalf of FIGO Menstrual Disorders Committee that was established in 2018, key parameters were defined, and they include the normal menstrual cycle, regularity of the cycle length, frequency of menstruation, duration of flow, and volume of bleeding. Their work established standardized definitions to aid in the classification and diagnosis of abnormal uterine bleeding. These parameters form the basis of assessing menstrual health and evaluating the impact of interventions like E2VDNG regimen, which has been shown to positively influence cycle regularity, reduce heavy menstrual bleeding, and improve overall menstrual comfort. Generally, we have since discarded terminologies like menorrhagia, metrorrhagia, and menometrorrhagia. And this system is known as the FIGO AUB System 1, while the FIGO AUB System 2 is the Palm-Cohen classification. So this guideline covers assessing and managing heavy menstrual bleeding. Next slide. Yeah. And managing heavy menstrual bleeding, and it aims to help healthcare professionals investigate the cause of heavy periods that are affecting a woman's quality of life and offer the right treatment, taking into account the woman's priorities and preferences. Next slide. Biza et al. Further emphasize that heavy menstrual bleeding extend beyond physical symptoms, significantly impacting women's social lives, emotional well-being, and intimate relationships. Next slide. This study was conducted to assess the efficacy of Estradiol Valerate dienogest combination administered using an estrogen step-down and progesterone step-up approach, as I have alluded to earlier. And it was a pooled analysis of data from two identically designed randomized placebo-controlled multiple center studies conducted in Europe, Australia, North America, that assess the effectiveness of E2VDNG in reducing menstrual blood loss in women with heavy menstrual bleeding. And they found that women aged 18 years and above with objectively confirmed heavy menstrual bleeding, those were randomized into E2VDNG and placebo. They found a significant benefit in those who were using the combination. You can read at your own time. Next slide. Fraser et al. Further demonstrated that the reduction in menstrual blood loss achieved with the E2VDNG regimen offers additional health and quality of life benefits beyond symptom control. And these include a decreased risk in iron deficiency and anemia, improved energy levels, and reduced fatigue. Next slide. RAID has done a lot of work in abnormal uterine bleeding, especially in adolescent girls. He compared treatment options for heavy menstrual bleeding and found that both the levonorgestrel releasing intrauterine system and the E2V-DNG oral contraceptive provide significant reduction in menstrual blood loss. Notably, E2V-DNG demonstrated a more rapid and substantial reduction in bleeding for some women, especially those preferring a non-invasive reversible method. Next slide. Again, this algorithm might be familiar. Biza et al. Highlight that medical management should be the first line of treatment for heavy menstrual bleeding, especially in the absence of the structural causes defined in the Palm-Cohen system. They outline several effective options, and these include the non-hormonal agents like tranexamic acid and non-steroidal anti-inflammatory drugs, and hormonal therapies such as levonorgestrel intrauterine system, combined oral contraceptives, including E2V-DNG regimen and progestins. And among these, E2V-DNG stands out for its dual benefit of reliable contraception and significant reduction in menstrual blood loss, offering a well-tolerated and user-friendly option for women seeking both symptom relief and cycle regulation, and also in vago intacta girls. Next slide. Davis et al. In 2013 explored the impact of progestin type on sexual dysfunction. So in regards to female sexual dysfunction, their findings revealed that switching to either a non-androgenic or anti-androgenic progestin, such as Dianogest, in the E2V-DNG combination was associated with a significant improvement in libido, arousal, and overall sexual satisfaction. And this underscores the importance of individualizing contraceptive choices, as the hormonal profile of a formulation can influence not only physical side effects, but also sexual well-being. Next slide. In regards to satisfaction rates, UQ et al. Reported high satisfaction rates among women using E2-DNG 4-phasic oral contraceptive, attributing this to a favorable bleeding profile, reduced hormone withdrawal symptoms, and good cycle control. Next slide. Petraglia et al. In 2014 and Schindler in 2011 both highlight the efficacy of E2V DNG in the management of primary dysmenorrhea. The combinations, anti-inflammatory and endometrial stabilizing effects result in significant reduction in menstrual pain intensity and duration. Dianogest has a strong progestogenic anti-inflammatory properties. It also inhibits neovascularization and inhibits angiogenesis. So this combination plays a key role in suppressing prostaglandin production, the main driver of dysmenorrhea, both in primary and secondary dysmenorrhea. So this study supports E2-DNG not only as an effective contraceptive, but also as a therapeutic option for women suffering from painful periods, including endometriosis, especially if they do not immediately desire fertility. Next slide. I know this is of interest to us. Is it safe? Are women susceptible to developing venous thromboembolism associated with oral contraceptives? So we know that the risk remains low for COC users. And Dinger et al. In 2007 and 2014, and Haight et al., they show that while COC slightly increase the risk of VTE compared to non-use, the absolute risk remains low in healthy women. The type of estrogen and progestin used can influence the risk. Therefore, Estradiol Valerate combination with Dianogest has shown a VTE risk comparable to that of low-dose ethinyl estradiol levonorgestrel combination, which are considered among the safer options. And according to the RCOG Green Top guideline number 40, Careful patient selection and individual risk assessment is important, particularly for women with additional VTE risk factors, because they remain at risk of VTE. So probably in that group of women, you might not want to use that combination. Next slide. Dinger et al. On the same, provided robust real-world evidence on the safety and effectiveness of combined oral contraceptives, showing that modern formulations, particularly those containing estradiol valerate and dienogest, offer reliable contraceptive efficacy with a favorable safety profile. The study emphasized that proper adherence and patient counseling significantly enhance outcomes, and that individual formulation choice, especially regarding estrogen and progestin types, can influence both tolerability and risk. And these findings support the continued use of tailored COC regimens like E2V-DNG for optimal balance between efficacy, safety, and user satisfaction. Next slide. Dinger et al. Further highlighted that E2V-DNG has a favorable safety profile concerning venous thromboembolism risk when compared to other combined oral contraceptives. Next slide. Again, this is supported by robust clinical trial data and further validated by strong real-world evidence from large observational studies and post-marketing surveillance. Next slide. In summary, the dynamic dosing of E2V-DNG oral contraceptive pill provides a highly effective contraceptive option with an adjusted PAL index method failure of 0.51 and an adjusted PAL index, that's the user failure, of 1. Therefore, it's acceptable in women aged 18 to 35. The combination is a modern, well-tolerated, combined oral contraceptive that offers both effective pregnancy prevention and additional therapeutic benefits, such as improved bleeding patterns, reduction in heavy menstrual bleeding, and relief from hormonal withdrawal symptoms. And with a favorable safety profile, especially regarding VTE risk, and strong support from both clinical trials and real-world data, E2V-DNG is a suitable choice for a wide range of women, particularly those seeking better cycle control, lighter periods, and enhanced quality of life. We also see its anti-resorptive properties in bone, especially in perimenopausal women. Next slide. Franca Fruzetti's work often focuses on contraception. This is my second last slide, and their work, including the development mechanisms and clinical aspects of various contraceptive methods, particularly combined oral contraceptives. She has written extensively on the pharmacology, clinical outcomes, and real-world effectiveness of different contraceptive options, including those containing estradiol. And her research also explores the challenges of contraceptive use in different clinical conditions and the importance of counseling for optimal contraceptive provision. Next slide. In summary, this is my last slide. In summary, to evaluate the efficacy of Estradiol Valerate, DNG, for the treatment of heavy menstrual bleeding and prolonged menstrual bleeding without organic pathology, based on the analysis of data from this study, from two identically designed, double-blind, randomized studies, the conclusion from this study was that E2V-DNG was more effective than placebo in reducing menstrual bleeding. Therefore, E2V-DNG is easy to use. It's 1 pill a day, every day, provides nearly 100% contraception, reduces menstrual cramps, provides positive reduction in menstrual migraine, positive effect on sexual function and quality of life. E2V-DNG provides 88% reduction in menstrual blood loss in 6 months of use. It reduces acne and hair growth, and also provides the beneficial effects associated with oral contraceptives. Thank you very much for listening.
Thank you, Dr. Owende, for a very deep and clear presentation. So audience, you can kindly post your questions, comments, clarifications on the chat box for Dr. Owende to answer and team. At this point in time, as Dr. Owende is taking a short break to swallow some water, I want us to move to the next phase of the presentation, which is a short and very brief panel discussion. Our panelists are again Dr. Owende and Dr. Ngoigo. Had already introduced Dr. Owende. I'll now invite Dr. Ngoigo to join Dr. Owende on stage. Dr. Ngoigo is a consultant obstetrician gynecologist, one of our youngest on the block, just like the product that you are discussing. Despite his young age, he's an HIFU specialist. HIFU, which is the newest, again, modality for treatment of especially uterine fibroids and endometriosis. He's also a sexual and reproductive health advocate. So as we are waiting for questions from the audience, I have a couple of questions that we received earlier from you guys that I'll pose to the panelists. Dr. Owende, I hope you've already taken some water after the presentation, and Dr. Ngoigo. So the first question, and guys, please post your questions and comments and clarifications on the chat box. Ian will help me to sieve them out, and then we'll read to Dr. Owende and Ngoigo to answer. So the first question to Ngoigo is, we know that in Kenya, we have a very high unmet need for contraception. How do you think Estradiol Valerate, then not just combination, the newest kid on the block, will support the broader reproductive health goals and address the unmet need for contraception globally and especially in Kenya? Dr. Ngoigo.
Hello, I hope you can hear me, Dr. Gwako. So first, I want to appreciate the great presentation by Dr. Owende. And I think in terms of how E2V DNG is likely to bridge the gap, we already know that there is, from the last KDHS statistics, we have, I think, less than 60% uptake of modern contraception, and therefore, E2V DNG, comes at the right time, especially because we know one of the reasons most of our women in the reproductive age bracket tend not to use, for example, COCs, which are, accessible and available in the market, is the issue of tolerability. And I think majority of times when you've encountered clients who have, been on some form of contraception, and especially the COC, they'll tell you maybe they dropped off within 3 months of use. And when you look at it, mainly it's because of the, the undesirable side effects, the breakthrough, or rather withdrawal bleeds. And of course, the question of, weight gain, which is a very common response from some of the women we see. So I think in terms of the, side effect profile that has been presented by Dr. Owende, we clearly can see that, E2V DNG has the benefit of reducing some of these side effects. For example, excessive, menstrual bleeding, which Doc has correctly placed that more than 88% reduction in the volume of blood loss, and therefore low HBs amongst these women is tackled. And of course, more importantly, the issue of cycle control, which makes majority of the women to drop off the COCs. I think once these two issues are tackled, then E2V DNG provides great promise for most of the women, especially adhering to these medications, and not only for typical use, but more importantly for perfect use of COCs, which I think is associated with efficacy in contraception.
Thank you, Dr. Ngoigo. The next question goes to Dr. Owende. And for the audience online, kindly continue posting your questions and comments. So Dr. Owende, after a very deep presentation, the question that most people will ask you, what makes E2V DNG unique compared to the other available oral contraceptives in Kenya? 2-3 words. What makes it unique compared to the rest?
Thank you very much, George, for that question. I think that's the essence of the discussion. Like I've basically presented the advantages of E2V DNG in terms of cycle controlled and contraceptive efficacy with a very low acceptable PAL index. So it makes it a favorable contraceptive.
Thank you, Dr. Owende. Dr. Ngoigo again. Another question is, I know about 30% of the women that we see in our outpatient clinics will have abnormal uterine bleeding, including heavy menstrual bleeding and dysmenorrhea, including endometriosis. What role do you see E2V DNG playing in some of these patients that we see?
Thank you very much. I think the presentation has been quite clear, especially on the issue of the non-contraceptive benefits. And I think one of the two things I must highlight, apart from contraception, is the issue of reduction in the issue of primary dysmenorrhea, because most of our young women commonly suffer this, and because unfortunately we have normalized it, I think E2V comes in because from evidence, it shows that there is a reduction in the days of dysmenorrhea, averagely about 3 to 4 days in reduction of severe menstrual pain. And I think tackling dysmenorrhea, tackling heavy menstrual bleeding, in fact even reducing the size of the lesion in endometriotic, women with endometriosis, not to mention the issue of ovarian cysts sometimes. I think there's a wide array of benefits which can be attributable to the quadriphasic dosing of this medication as compared to older COCs, which are mainly monophasic.
Thank you, Dr. Ngoigo. As we continue getting the questions online, the last question again to Dr. Owende. I think you already covered this very well. You mentioned that E2V DNG is 200 to 20,000 times more potent than ethinyl estradiol, which then brings me to the question of safety. And for women who have safety concerns, especially those who have a high risk of VTE, and then there's the question of the use of the E2V DNG in women who are lactating. What would be your comment about that?
Thank you, George. Yes, I'll start with the last question. I don't think we have any reasonable data in lactating women. So my advice would be not to administer to lactating women. And secondly, in terms of VTE risk, as I have alluded to, that ethinyl estradiol is 20,000 times more potent. It's a synthetic estrogen. While E2V, that's the Estradiol Valerate, is a natural estrogen. from some of the studies that I mentioned earlier, it basically has a lower risk on VTE, especially for women who have low risk for VTE, but generally for high risk, women with high risk VTE, those you still do not want to administer combined oral contraceptives, however low the risk is for E2V DNG. So basically what I am saying is that for high risk women, you want to avoid using E2V DNG, just like you'd want to avoid the other combined oral contraceptives. But in terms of safety profile on VTE, it has the lowest risk.
Thank you, Dr. Owende and Dr. Ngoigo. There are a few questions in the chat box. Several comments congratulating you for a very good and informative presentation. There is a question from Dr. Guerre. He's asking about, maybe could be beyond the scope, but can you explain why some patients with abnormal uterine bleeding due to structural causes continue spotting despite having the levonorgestrel intrauterine system in situ? And is there any remedy for this? Dr. Owende, if you have a response to that.
Thank you. I think it is self-explanatory because, thank you, Dr. Were, for your question. You talk about the structural causes. In our discussion, we mentioned that you want to rule out the structural causes, and that's why FIGO, Menstrual Disorders Committee, came up with the abnormal uterine bleeding system 1 and abnormal uterine bleeding system 2, basically the palm coin that looks at the structural causes of bleeding. So for structural causes, you may want to administer E2VD probably to help reduce the bleeding, but you might not be able to cure the patient unless you sort out the structural cause. For instance, if one has submucous myoma and you give E2V-DNG or intrauterine levonorgestrel system, the woman might still continue to spot until you sort out the structural cause.
Thank you, Dr. Owende. There is a question on cervical cancer from Dr. Eli. So the question is, data on cervical cancer risk is mainly on EE-based COCs. Can the findings be extrapolated to E2V?
That's a very interesting question. And, you know, to a carpenter, everything looks like a nail to be hammered. So I can see where Ellie is coming from, being a gynae-oncologist. I think that's a very good question, but I don't think at this point in time, I haven't seen any studies looking at that, but probably by inference, we can say that probably the risk, being a natural estrogen, it's probably less risky than the EE, which is a synthetic estrogen.
Thank you, Dr. Owende. Several other congratulatory messages. 2 more questions. The second last question is whether E2V can be used as a menopausal replacement therapy for management of vasomotor symptoms. That's from Dr. Joey.
Hello, thank you. I think from what you've seen, we know that most of the vasomotor symptoms, in menopause are attributable to the decline in the levels of estrogen. And I think from what Dr. Owende has presented, we've seen that E2V DNG has, compared to earlier COCs, it has lower amounts of natural estrogen, which is actually safe if you use within maybe a period of about 6 months. We already know that when you do hormone replacement, one of the other important elements is actually to do add-back therapy, and we can already see that this molecule has a 4th generation progesterone, and therefore, going by the the pathophysiology of the vasomotor symptoms, I believe this is a molecule that we can actually use for our women with menopausal symptoms, vasomotor symptoms.
Thank you, Dr. Ngoigo. The next question, you can keep them coming, but the next question is actually to Bear, and you allow me to move to the third part of the presentation. At this point in time, I want to invite a representation from, or a presentation from Bear, the sponsors of today's CME. So I want to introduce Elsie Engelbrett, who is a women's health brand and customer lead for Bayer in sub-Saharan Africa. She's based in Johannesburg, South Africa. She has spent the past 21 years in the pharmaceutical industry, but her passion for women's health goes far beyond her job title. She's a mother to two incredible teenage daughters and is deeply committed to making a meaningful difference in the lives of women, supporting their health, their choices, and their futures. For her, this work is personal. Every day, she's inspired by the strength and the resilience of women.
George, for that.
And she's very proud to be part of a mission that puts their well-being at the center. Welcome, Dr. Elsie, to the floor. Floor is all yours.
Thank you, Dr. George, for those introduction, and thank you, Dr. Philomena, for those comprehensive talk. I think that we learned so much. Thank you very much. It gives me great pleasure to introduce to you Clara. This product is taking the cue from nature with an estrogen that's identical to our body's own. It has 2 registered indications then, you can see on contraception, and then also heavy menstrual bleeding. The regimen is, as Dr. Philomena said, a 26-2 with active ingredients then of Estradiol Valerate and Deonogest. This unique product took Bayer 30 years to develop to ensure that you have the perfect combination of Estradiol Valerate and Deonogest with a unique dynamic dosing. Next slide, please, Tina. So if we're looking at the pack shot, the dynamic dosing is then evident with the Estradiol Valerate following a step-down approach, and the Deonogest follows then a step-up approach. And then we have at the end 2 hormone-free tablets. Next slide. As Dr. Philomena comprehensively explained the MISPL rule, from Bayer's side, the MISPL index is then printed onto the wallet, so it makes it very much easier for our patients then to follow. Next slide, please. Looking closer at this beautiful product, the benefits beyond contraception is in the combination then of the 3. It's then firstly our Estradiol Valerate, Deonogest, and the unique regime. This will then have 80% of young women who switch to Clara had very satisfied or satisfied with the product. Next. And then in summary, if we look at it, it's an easy to use 1 pill a day every day. It provides nearly 100% contraception. It reduces menstrual cramps. It provides positive reduction in menstrual migraines. It positively affects sexual function and the quality of life. Clara provides 88% reduction in menstrual blood loss in 6 months of use. It reduces acne and then hair growth, and it provides beneficial effects associated with oral contraceptives. We will, to the next slide, we will appreciate if you would provide us some feedback regarding tonight's meeting by scanning the QR code, or alternatively follow the link in the chat. I now call on the Kenyan team to please unveil the newest lady on the Kenya market, Clara.
All right. Thank you so much, Ilse. Thank you, Dr. Philomena. We really appreciate even the large organization COGS for giving us this good platform to engage with all the membership. And I believe that our work with Bear Women's Health, especially, and all the ops guys, it has been a very, very long and fruitful work for many years, because Bear, by its main strength, is very heavy in terms of women's health. Yeah, my name is Harun Mwangi. I'm standing here because we represent Bear Pharma, and I'm not alone. I am with many of my colleagues. Maybe they can lift up their hands from wherever they are. They came to give us a lot of moral support and many good things that has been spoken about Clara. And I think most of us are wondering, how does this lovely baby look like? So in a few minutes, we will be unveiling the newest kid in the block. And we are starting this in Kenya. And I believe we'll also be able to spread this good message to other countries in East Africa and also in West Africa in the days to come. So allow me to welcome Tina on stage. Yeah, she can say a few words about the new kid.
Good evening, everybody. My name is Tina Visser. I'm the medical lead for women's health at Bayer, also based in Johannesburg. And it really gives us great joy to give women more options. At Bayer, our intention is that every child should be a wanted child. And therefore, every day when we wake up, there's quite a big and huge burden on our shoulders. But yes, we hope that Clara will give women more options to also address underlying other needs that's not normally expressed. We want you as physicians to please ask patients questions about their heavy menstrual bleeding, about their bleeding patterns, about the symptoms that they are experiencing while on a combined oral contraceptive that is affecting their life. And as Bayer, we are really very proud to add this to the Kenya market. Thank you, Arun.
Yeah, thank you so much. Please don't go. Yeah, and before the product reaches our market, there is a lot of very committed team members who make sure that the product, number one, is registered, comes in the right quality. And I would request the team, Bayer regulatory team, well, just to stand up. We acknowledge Sneha, ICU, medical governance, ICU. Please stand up. We just want to give them an applause. Yeah, they really help us to make sure that everything, the patient gets the best right as it was manufactured. Thank you so much. You may have your seat. And lastly, I want to thank everyone who joined online. So at this moment, I also want to welcome our speaker, Dr. Ngoigo, please come. Tina, John Mwangi, you can come over. Augustine. All right. So I think ladies are good in receiving babies. They hold the baby first time. So we'll allow one of you to hold the scissors, and then we'll unveil the baby.
So this new baby, we celebrate her because she's going to have, every baby is wanted. And so we can cut the ribbon and celebrate this new baby. And 5, 4, 3, 2, 1. Oh, this side. Oh. Woo! Yeah. Thank you. Thank you. So, I don't know if you wish to tell us something. All right.
All right. Thank you so much. I will allow Elsie to tell us. There's one thing she has not said, that it comes in a very nice pack. They call it the wallet. And I want to give this chance to Elsie to mention.
Okay. So if you look at the wallet, if you open it up, it is then, as I said, first and foremost, the MISPL rules and guides are into the packet. And then it's very easy to start. It's got lots of stickers. And the day you start with this pack, you choose the sticker with the date and you place it then onto that, onto your day. And then you follow all the arrows. Once a day, every day on the same time, you take your pill, and then you have the best of Clara. Thank you. On the tables, there is a QR code for those of you that want to have more extra information. These are then just the patient information that we are supplying for patients that has been prescribed Clara. So you're more than welcome to take out your phones and just scan the QR code if you want to have more information. Thank you very much, everyone.
Thank you. Thank you.
All right, that marks the end of Bear session. I want to hand it over to the moderator to conclude the meeting. Thank you.
Thank you, Team Bear. There you have it. Baby Clara has been born in Kenya. So for the final comments, we can have the closing remarks from Ngoigo and then Dr. Owende. Ngoigo, closing remarks, then Dr. Owende, then we'll call it an evening.
Okay, thank you very much. I want to appreciate the Bear team and our presenter today, Dr. Owende, for the enlightenment. And I think it's about time as healthcare practitioners, especially gynecologists, to provide these options to our women, and especially where there is improved compliance, better safety profile, and of course, more benefits. So I'm very glad to be associated with this product, and I hope we can provide more options for our women. Thank you.
Thank you very much, George, for being our moderator this evening. Thank you, Bear, for providing us such a wonderful product. This is what we have been looking for. The women are saying we want a natural product. We want one that is safe, efficacious, and so you have answered what the questions the women have had for a long time, because it has very little impact on libido. So we see people complaining less of contraceptive that is going to impact negatively on libido, better cycle control, and offering contraception efficaciously. So thank you very much for such a wonderful product. And to the audience, thank you for joining us this evening. We hope we'll provide these options to our women. And I don't know whether we are joined by anybody in policy, because this will be important in cascading it and also just including it in our national formulary so that it can reach the last mile. Even the poorest should be able to access it. And a challenge to Bear that this product should be available even to those who might find it difficult to afford. Thank you.
Thank you, Dr. Owende. I think I saw you talked about policy, but at the same time, I think I saw the president of COGS, and because the CME was co-sponsored by COGS, Dr. Kireki, are you in the house to formally close the meeting? I know it's such an ambush, Dr. Kireki.
Hello.
Okay, then yes,
Hello.
Dr.
Hello.
Kireki.
Yes.
Yes, we can hear you, Mr. President.
I'm in the house. I'm in the house. Good morning, ladies and gentlemen. I want to thank the presenters, Dr. Owende for that beautiful presentation, Dr. Ngoigo, the moderator as well. We are grateful that this CME was co-sponsored by Bayer. We want to work together with Bayer. We want to collaborate together so that the women in Kenya will have options when it comes to contraceptive pills. And I think this is a beautiful and strong option, which is very safe and should be propagated to all our ladies who are eligible. And I'm sure they will benefit immensely from it. And I'm grateful. Thank you on behalf of COGS, Bayer, and we're looking forward to working together. And then apart from that, I'm also inviting you, Bayer, to come to our 50th anniversary, and all of us who are online and in-house, as it were. We are organizing our 50th anniversary of COGS. So, Bayer, please welcome. Thank you very much, and a very good night to all of you.
Thank you, and good evening, everybody.
All right. Thank you so much for those of us who came here. Physically, it's a great sacrifice. We don't take it for granted. Yeah, onward from here, I just asked you to give a little bit of guidance. What do we need to do from here?